Welcome back to the deep dive. All right, let's jump right in. Today, we're tackling a topic that, frankly, you might not encounter every single day, but when you do, understanding it is absolutely critical. We're doing a deep dive into gestational trophoblastic disorders, or GTD. Think of this as a specific, fascinating area of medicine, intimately linked with pregnancy, but involving abnormal cell growth that can range from relatively benign to quite serious.
That's right.
We've got a stack of notes on GTD right here. And our mission, as always, is to cut through the complexity, pull out the absolute most important, high-yield information, and get you informed fast.
And these disorders are truly unique, really stemming from the cells that would normally form the placenta. The abnormal growth pattern is the key here.
And the notes make it clear this isn't just one single condition, right? It's a whole spectrum.
Exactly. There's a significant range. On one end, you have conditions considered premalignant, like the Hydatidiform mold. Then you move into the malignant forms, collectively known as Gestational Trophoblastic Neoplasia, or GTN. GTN includes the invasive mole, Choriocarcinoma, and the less common types like placental site trophoblastic tumor and epithelioid trophoblastic tumor.
Right.
The source also notes that persistent elevated HCG levels after treating a mole also fall under that GTN umbrella.
Okay, let's unpack this then. What specifically are gestational trophoblastic disorders?
Well, at their core, as we mentioned, they are rare conditions tied to pregnancy that involve abnormal proliferation of trophoblastic cells.
These are the cells destined to become the placenta.
Precisely. And the source lists the primary types we need to know: Hydatidiform mole, invasive mole, choriocarcinoma, and placental site trophoblastic tumor.
So you mentioned the Hydatidiform moles are the premalignant ones. What's the breakdown there, like complete versus partial?
Yeah, good question. The source details the two main types of Hydatidiform mole. A complete Hydatidiform mole is described as a benign tumor, and it results from a really specific genetic event: the fertilization of an empty egg, one with no genetic material, by a single sperm, which then duplicates its own DNA.
Wow, okay.
So this means all 46 chromosomes are of paternal origin. There's no maternal genetic contribution at all. It's diploid and androgenic.
And no fetal tissue.
Crucially, yes, absence of any fetal tissue in a complete mole. In contrast, a partial Hydatidiform mole is typically triploid.
Triploid, 3 sets.
3 sets of chromosomes, exactly. Usually 2 from the father and 1 from the mother. This most often happens when an ovum is fertilized by 2 sperms simultaneously.
Okay.
And with partial moles, you often do find some evidence of fetal tissue, and the source mentions focal hydropic changes.
Wow, so the difference comes right down to the genetic origin during fertilization. That's fascinating. And these abnormal growths can sometimes turn malignant, becoming GTN.
Precisely. Choriocarcinoma is a malignant form that the source highlights. It's particularly noteworthy because it can develop not only after a molar pregnancy, but also after a normal pregnancy, even a live birth.
After a normal pregnancy.
Yes, this form is aggressive and can spread. The source also briefly lists PSTT, that's placental site trophoblastic tumor, and ETT epithelioid trophoblastic tumor, as other rare malignant types that can follow any pregnancy.
That's quite a key point, the potential to arise even after a normal pregnancy. So that explains what they are and the different types, especially those distinct genetic origins of the moles. But why do these happen? Why do these abnormal fertilizations occur? Or why do these conditions develop in the first place? What's the etiology?
Well, interestingly, the source mentions that the overall cause is actually poorly understood. However, the clear link is to abnormal fertilization events that lead to that initial abnormal development of the trophoblastic cells.
Right, which we saw with the specific genetic origins for the moles you just described.
Absolutely. The source really emphasizes that distinct genetic basis. For a complete mold, like we said, it's all paternal genetic material, 0 maternal genes,
Right.
usually that single sperm fertilizing an empty ovum and duplicating.
Okay.
And for partial moles, they are typically triploid, so it's that fertilization of an ovum by 2 sets paternal, 1 set maternal.
So abnormal wiring right at the very start.
Yep.
Okay. Moving from the why to who.
Mm-hmm.
Who is more likely to develop GTD? Are there specific risk factors the source points to?
Yes. The source lists several clear risk factors. Maternal age extremes are definitely significant. There's an increased risk for women over 45 years old, or surprisingly under 16.
Under 16 and over 45. That's quite a wide risk window.
It really is. A previous history of GTD, or specifically a molar pregnancy, is another major risk factor. The source notes the risk goes up with multiple previous moles.
Okay, makes sense.
And here's where it gets specific. The source highlights ethnicity. Asian women have a higher incidence. Yes, the source even provides a UK statistic. Roughly 1 in 387 pregnancies in Asian women are affected, compared to the general UK incidence.
Wow.
The source also mentions potential links, though maybe less definitive, to things like menarche over 12, light menstruation, and maybe a history of oral contraceptive pill use, suggesting these may carry higher risk.
Interesting.
An increased risk is also noted for multiple pregnancies, but mainly in the context of already having a previous history of molar pregnancy.
Okay, so age extremes, past history, and ethnicity are definitely key takeaways from the source regarding who might be more susceptible.
Got it.
Now, let's get into pathophysiology. What is actually happening inside the body as these conditions develop?
Well, the fundamental process involves the uncontrolled abnormal growth of those trophoblastic cells.
Right.
The source describes how this can lead to physical changes like the polypoid mass seen in complete moles or the cystic changes found in partial moles. And the source specifically mentions, quote, can lead to the formation of grape-like clusters in complete mole.
Grape-like clusters. That's a memorable description the source uses. And these abnormally growing cells can, invade nearby tissue.
Yes, that's where the complications can really start. The source explicitly states that invasion into the uterine wall can occur, which is the characteristic feature of an invasive mole. And with more aggressive forms like choriocarcinoma, this invasion can extend far beyond the uterus, leading to metastasis to other organs.
Right, spreading elsewhere. Given that initial symptoms can be a bit vague, maybe like a threatened miscarriage,
Yeah.
what else might doctors need to consider? What's on the list for differential diagnosis?
Yeah, that's important. The source lists conditions that need to be ruled out because they can present with similar symptoms, particularly bleeding or unusual scan findings early on. These include threatened miscarriage, definitely ectopic pregnancy, and other placental abnormalities. Distinguishing GTD from these is crucial for getting the right management quickly.
Right, misdiagnosing this would have serious consequences. So how common are these conditions, say, in the UK? What does the epidemiology tell us?
According to the source material, molar pregnancy occurs in approximately 1 in 500 to 1,000 pregnancies in the UK.
Okay, so not super common, but not vanishingly rare either.
Exactly. And looking broader at GTD as a whole, including Hydatidiform, mole, invasive mole, choriocarcinoma, PSTT, the source estimates an incidence of about 1 in 714 live births. And as we noted with risk factors, the incidence does vary significantly based on maternal age and ethnicity, reinforcing that higher rate in Asian women and at the extremes of reproductive age.
Mm-hmm.
The source also adds a little note that the true incidence may actually be underestimated.
Oh, why is that?
Potentially due to reporting issues, especially for partial moles, which might sometimes be misdiagnosed as simple miscarriages.
I see. And what about the malignant forms, GTN, specifically developing after a non-molar pregnancy? How rare is that?
The source gives an estimate for GTN developing after a live birth as being much rarer, around 1 in 50,000.
Okay, very rare then.
Yes. But it's a key point that GTN can follow any pregnancy-type molar, non-molar, or a live birth.
So, thankfully rare overall, but definitely something clinicians need to keep in mind. What are the typical signs and symptoms then? What might trigger suspicion for GTD? What clinical features does the source list?
The source details several presentations, often seen in the first or early second trimester. The most common symptom by far is irregular vaginal bleeding.
Which, again, overlaps with other pregnancy issues, like you said.
Exactly, hence the need for that differential diagnosis we mentioned. Other symptoms listed are exaggerated pregnancy symptoms, like really severe nausea and vomiting hyperemesis gravidarum,
Right.
or a uterus that seems larger than expected for the gestational dates, size greater than dates. But the real hallmark, the key diagnostic clue the source points to, is very high serum HCG levels.
The pregnancy hormone.
That's the one. But in GTD, particularly complete moles, these levels can be astronomically high compared to a normal pregnancy.
So that super elevated HCG is a major red flag then?
Yes, absolutely crucial for diagnosis and for monitoring later on. The source also notes that hypertension and hyperthyroidism may be seen in some cases, which can be linked to those very high HCG levels.
Interesting.
Less commonly, if the disease has metastasized, particularly with choriocarcinoma, symptoms could include things like hemoptysis, coughing up blood, acute respiratory failure, or neurological symptoms if it has spread to the brain.
Wow, those metastatic symptoms sound quite severe. So how do doctors investigate and actually confirm a diagnosis when they suspect GTD? What are the investigations?
The diagnostic process, as detailed in the source, relies on a few key steps. Number 1 is measuring serum beta-human chorionic gonadotropin, or BCG levels.
The HCG again.
Yes, these are absolutely critical. For diagnosis, especially noting those abnormally high levels we talked about,
Hmm.
and for ongoing monitoring throughout treatment and follow-up. Really central. Ultrasound is also a vital early investigation. The source describes typical findings. You might see a sort of polypoid mass in complete molar pregnancies or cystic changes in partial molar pregnancies. This is often what initially raises suspicion on a scan.
And the definitive confirmation, how do they know for sure?
That comes from histopathological examination of the tissue that's removed, looking at it under the microscope.
Right.
The source clearly outlines the microscopic differences. A complete mole shows no fetal tissue and extensive hydropic changes, while a partial mole does have fetal tissue present along with focal hydropic changes. This analysis confirms the specific type of mole.
Okay, so HCG, ultrasound, and looking at the tissue itself are the key diagnostic steps. What about if metastasis is suspected? With something like choriocarcinoma, how do they figure out the extent of spread?
Good question. If metastasis is suspected, the source outlines staging investigations using the FIGO system, that's the International Federation of Gynecology and Obstetrics Staging.
Okay.
This involves imaging to look for spread to other organs. They'd use a Doppler pelvic ultrasound to check for local spread in the pelvis, maybe assess vascularity. Then a chest X-ray, or more likely a lung CT scan to look for lung metastases. Lungs are a common site.
Mm-hmm.
A CT scan can check the liver or other abdominal metastases, and an MRI scan is used specifically for brain metastases if those are suspected. And the FIGO system itself, mentioned here, is the standard way to stage gestational trophoblastic neoplasia. It gives a clear picture.
How does that work? What are the stages?
Basically, stage I means the disease is confined just to the uterus. Stage 2 means it's spread outside the uterus, but it's limited to the genital structures like the vagina or ovaries.
Okay.
Stage 3 involves spread to the lungs, whether or not there's also genital involvement. And stage 4 covers metastasis to all other distant sites like the brain, liver, kidneys.
So the FIGO staging gives a clear picture of how far the disease has progressed.
Right. Once a diagnosis is confirmed, what does the management involve? What's the treatment approach?
Well, the management strategy depends heavily on the specific type of GTD and its extent, based on that staging we just talked about. For Hydatidiform moles, both complete and partial, the primary and most urgent step is evacuation of the uterus.
Evacuation, how is that typically performed?
The source states that suction curettage is the standard method. It's used for evacuating both complete and partial moles. It does note that partial moles with significant fetal parts might make suction curettage slightly more challenging. Medical removal is also mentioned as being used in some cases, though the source doesn't really detail when or how.
And if there's heavy bleeding?
Then surgical evacuation is done urgently, absolutely,
Yes.
expedited for significant hemorrhage.
And what happens after the uterus is evacuated? Are there important follow-up steps? That seems crucial.
Yes, crucial ones according to the source. Effective contraception is strongly recommended for 12 months following the evacuation. 12 months, okay. Why so long?
It's vital because it prevents a new pregnancy from interfering with the monitoring of HCG levels. Remember how important HCG is? Monitoring it is the cornerstone of follow-up to ensure the GTD has resolved. A new pregnancy would raise HCG levels and confuse the picture.
Ah, that makes perfect sense. Anything else post-evacuation?
Yes, anti-D prophylaxis is necessary after the evacuation of partial moles. That's because of the potential for fetal tissue being present. And the source also specifically advises that oxytocin infusion is not recommended during the evacuation procedure itself.
Right.
Post-evacuation, there's a specific UK protocol for surveillance after a Hydatidiform mole. This involves serial monitoring of serum and urine HCG levels. Samples are sent every 2 weeks until the HCG concentration normalizes.
Every 2 weeks.
Yes, until normal. The source mentions that the total duration of this follow-up period is different for complete versus partial moles, though the exact timelines aren't detailed here in this source.
So that rigorous HCG surveillance is key to making sure the condition is resolving and doesn't progress or persist as GTN. When is chemotherapy necessary then?
Chemotherapy is initiated if there are signs that GTN is developing or persisting after the mole evacuation or based on other risk factors. The source lists the specific indications if the HCG levels plateau or start rising again after the initial evacuation.
Okay, so if they don't go down properly or start climbing back up.
Exactly. Or if the histology confirms choriocarcinoma from the start, or if there's clear evidence of metastases on scans or suspicious radiological opacities, or if there are other specific high-risk factors according to that FIGO scoring system.
And are the chemotherapy regimes different depending on how risky the case is,
Yeah.
based on the FIGO score?
Yes, they are tailored. For low-risk GTN cases, typically defined by a FIGO score of 6 or less, the standard treatment, according to the source, is single-agent intramuscular methotrexate.
Just one drug.
Usually, yes. For high-risk cases, though, a more intensive multi-agent intravenous chemotherapy regime is used. Treatment continues until those crucial HCG levels return to and remain within the normal range.
Got it. Any other important points about management from the source? Seems quite involved.
The source adds a few practical points. Registering with a specialist GTD center is essential. These centers have the expertise for management and surveillance.
Makes sense.
It highlights that twin pregnancies, where one twin is a mole, carry specific risks. Prophylactic chemotherapy may be considered in certain high-risk complete mole cases, even before GTN is confirmed. It also advises against using intrauterine contraception, like IUCs or coils, until HCG levels are back to normal. And obviously, emergency contraception should be used if needed to avoid pregnancy during that surveillance period. Following guidance from healthcare professionals is paramount.
That's a really comprehensive picture of management, emphasizing the need for specialized care and that diligent follow-up. Given all that, what's the long-term outlook, the prognosis? What does the source say about that?
This is where the news is generally very good. The prognosis for gestational trophoblastic disorders is excellent, particularly for Hydatidiform moles that are properly managed. The source highlights incredibly high cure rates.
How high?
In the UK, for patients managed at specialized GTD centers, the overall cure rate is between 98% and 100%.
Wow, 98 to 100%. That's amazing.
It really is. Even for gestational trophoblastic neoplasia requiring chemotherapy, the outlook is excellent. Especially for those low-risk cases, the FIGO score A6, where the source states the cure rate is almost 100%. Even higher-risk cases needing multi-agent chemo have very high cure rates with specialized care.
That's incredibly reassuring, especially given the potential severity we talked about. What about fertility and future pregnancies after treatment?
The source provides positive statistics here, too. Approximately 80% of women treated for GTD go on to have further successful pregnancies.
That's great news.
Yeah. The risk of having another molar pregnancy in the future is low, generally around 1%, though it's slightly higher if the previous one was a complete mole. The source does mention one potential issue: an increased risk of preterm birth for women who had a molar pregnancy before their subsequent live birth.
Okay, something to be aware of.
And one other potential long-term consideration from the source, particularly for those who undergo combination chemotherapy for high-risk disease, is the risk of premature menopause, which obviously can impact future fertility.
Right.
It suggests considering things like exogenous estrogens and fertility drugs once HCG levels have normalized in these specific cases.
So overwhelmingly positive outlook with the right care, which is fantastic, though with some specific long-term considerations to be mindful of. Finally, what are the potential complications of GTD that the source lists? What can go wrong?
The source lists the primary complications that can arise. One is persistent gestational trophoblastic neoplasia, basically, where the condition doesn't fully resolve after initial treatment or it recurs, requiring further treatment, usually chemotherapy.
Okay, persistence or recurrence.
Another is metastasis, especially with forms like choriocarcinoma, where the disease spreads to distant organs like the lungs or brain.
Right.
And lastly, as is always the case with potent therapies, there are potential adverse effects from the chemotherapy itself, short-term and potentially long-term side effects.
Okay, well, this has been a really thorough deep dive into gestational trophoblastic disorders. We've gone through everything from the unusual genetics behind the moles, the key risk factors like age and ethnicity, how these conditions affect the body, how absolutely crucial those HCG levels are for diagnosis and monitoring alongside imaging and histology. The detailed management involving evacuation and potentially tailored chemotherapy based on risk scoring.
And that vital surveillance.
Exactly. And thankfully, the overwhelmingly positive prognosis with specialized care and that diligent follow-up.
It really underscores the unique nature of these conditions, doesn't it? Arising from pregnancy-related tissue, but behaving potentially like a malignancy. and it highlights the critical importance of timely diagnosis and expert management at specialized centers, especially that vital post-treatment surveillance the source keeps emphasizing.
Absolutely. And, thinking about that essential, rigorous surveillance required after treating GTD, especially given the potential for persistence or recurrence, how does understanding the specific example of diligent post-treatment follow-up shape our thinking about the broader importance of continued monitoring in other complex medical conditions we encounter? It's a really valuable takeaway for you to consider. We hope this deep dive into gestational trophoblastic disorders, based entirely on the source material you shared, has helped you quickly consolidate your knowledge on this specific topic. And if you're looking to dive even deeper and reinforce your learning, particularly maybe for revision purposes, you can find resources at passthemsra.com and freemsra.com. Thanks for joining us for this deep dive. Bring us your sources, and let's unpack them together next time.